Hello and welcome. Welcome to the Critical Care Canada Forum webinar. This afternoon or this morning or evening, depending on where you are, we have a Professor Philip Schutz from the University of Basel presenting. He's a professor at the University of Basel and head of department. His research is involved in both looking at clinical nutrition in patients as well as biomarkers. And he's led both multi-center large randomized controlled trials and observational studies. His topic today is procalcitonin, and the title of his presentation is Procalcitonin, Optimal Clinical Application in Sepsis and to Assist in Antibiotic Decisions. So with that, I'll hand it over to Professor Schutz, and thank you very much for presenting.
Yes, thank you very much, Dr. Friedrich. And dear colleagues, it's a pleasure to present about procalcitonin. I used to be a student in Canada, actually in London, Ontario, and I have a great memory from that time. I was in neurosurgery and also went to visit Quebec and Toronto and a lot of other cities in Canada. So I have very warm feelings. So today I'd like to share with you my talk, Procalcitonin, Optimal Clinical Applications in Sepsis and to Assist in Antibiotic Decisions. And I think it's an interesting topic. How can we use a biomarker to improve our clinical management of patients with sepsis, with infections, and can biomarkers such as procalcitonin help us in doing better antibiotic decisions in these patients? So as for a conflict of interest, you see that we have received some support from industry for our studies. And the objectives of my talk today are as follows. I'd like to first talk a little bit about what is procalcitonin, how is it regulated, what should we expect regarding kinetics. I'd like to share with you strengths and limitations of traditional markers and procalcitonin. And I think it's important if we work with biomarkers to really understand these markers and the limitations they have in clinical routine. Then I would also like to share with you data demonstrating how PCT, procalcitonin, can be used to assist you in the antibiotic management of patients. And I'd like to do then some conclusions based on the trials that we have today. So obviously there is a big killer out there, and today maybe this big killer is more COVID-19, but of course, sepsis and just infections overall, it's causing a lot of mortality, morbidity, and you all are involved in a lot of sepsis care and a lot of infection care, and of course it's important that that we have a good and rational management of these patients. So what do we, what is our approach in the patient with sepsis? And I think most important, and this has been backed up by many research trials and studies, is early recognition is key. And I think that it's obvious that once you recognize a patient is sick and is having a sepsis, an infection, and you can start your fluid management, your antibiotics, this is really time matters here, and it's very important. So recognition and then initial resuscitation, with antibiotics, with fluids. But then once you have your patient on the IC ward or the medical ward, I think it's the diagnosis management and the monitoring of patients with supportive management, which is important. And I think, for all these different tasks, of course, we have our clinical, management of the patient, but we also have help with some other tools. And I think the biomarkers are one of these tools we can use. So how can PCT, be of any help here? How can it help us to early recognize, infection, or maybe help us triage, the severity of infection? Can it help us to stewardship antibiotics in the initial resuscitation period? Can it be of help maybe for the de-escalation of antibiotics once you have your patient on the ward, on the ICU. So this is what I would like to talk about. So, I'd like to cover like three basic questions for PCT. So first of all, is it really a prognostic marker that can, provide prognostic information beyond that we have already when we see the patient, beyond that of other ICU risk scores or severity risk scores? And of course, with prognostic information, it's always nice to have a prognostic information, but it's always hard to actually use this information clinically, because if a patient has, his prognosis is not very good, I mean, what are you going to do different, right? Maybe if you can say, well, his risk of really developing severe infection is very low, this may be a patient you send home. But overall, it's not so easy to use prognostic information, clinically. I think then the second question, can we use PCT to actually influence our antibiotic decisions? And I think this is, from a clinical perspective, may be more interesting. So the question is, if a patient comes in and he has a low PCT level, should we use that level to rule out bacterial infection, which would mean, we don't give this or we don't treat this patient with antibiotics. Once we have the patient on the ward and his PCT drops or his PCT remains low, can we use this as a guide or as a sign then to early stop antibiotics? And then I think the four most important question, if we use a marker like PCT, do we really have an impact on the outcome of our patients? And I think this is really key for us clinicians, because of course we want to improve the outcomes of our patients, and we have a lot of tools, and we have to understand, are these tools really helpful in improving clinical outcomes in the patient? So for my talk, I'd like to use two clinical case studies. So the first one, and you see this image here from the Netter, and it's a patient with a COPD, and you see it's an older patient. He comes in with a cough. He feels feverish. He doesn't have really an infiltrate on his chest X-ray. But this patient feels like he's having an infection. And as a GP or as a emergency department physician, you're getting worried about the patient, because COPD is a condition that puts him at risk. So you don't want to be the one missing the bacterial infection, and so it's hard not to treat this patient with antibiotics. Although you may understand that most part of these infections are not bacterial infections, but most of these COPD exacerbations may just be viral exacerbations. So antibiotics, do not bring benefit in most of these patients, I would argue. And we really are very limited for these patients regarding diagnostic tools. So if we do, blood cultures or sputum cultures, a lot of the blood cultures are negative, even though we suspect bacterial infection. So the sensitivity is just horrible. We can do, white blood count, we can do CRP, but mostly these are a little bit elevated. White blood count, these patients often have steroids, and you're not sure, is it the steroid, is it the infection? Then we do the chest X-ray. And then, again, we know from studies, if we do a chest X-ray, we don't see an infiltrate, and we would do a CT scan in the same patient, then we see much more infiltrates in these patients. And in the end, the infiltrate just tells us there is inflammation in the lung. It doesn't tell us, what is causing the inflammation. So in this scenario, I would say low risk for bacterial infection patient, what's the impact of adding the biomarker to the clinical tools we have? So this patient clearly does not have sepsis, but I would argue that these types of patients, are the ones causing most of the antibiotic overuse that we see, in GP care and in the emergency department care, and may even, in the ICU. Now, the second, case scenario I would like to show you, is another patient, a patient where we have established the diagnosis of sepsis. So a patient that is really sick, that is, having, an infiltrate, and he has a pneumonia. And he's clearly going into shock, and it's very clear that we will need antibiotics right away and fluids. And so, clearly in this situation, the biomarker is not going to guide us in any way, initially, whether we should use antibiotic or not. But this patient is going to, stay on the ward for a couple of days. And we have learned, while 10 years ago, we used 14, 20 days antibiotics for these patients with pneumonia, we have learned that probably much shorter doses are similarly effective and have much lower risks than for side effects. So for this type of patient where the bacterial infection is clear, the biomarker is not going to influence our initial treatment for this infection, but it may influence how long we treat, because the biomarker kinetic, when it drops or doesn't drop, may give us information whether this patient was successful in recovering, in killing all the bacteria by the immune system and the antibiotics, or whether this was not the case and whether we should continue our treatment. So let me start with the first question. So prognostic information. And I think there is a lot of studies demonstrating that PCT does have prognostic information. And it's not so much the initial PCT level that we see when a patient comes into the emergency department or the ICU that is important, but it is really the kinetic. And so in this cartoon, you see different biomarkers after endotoxin injection, and you can see that IL-6 is a very fast reacting biomarker, but it also drops very fast. And because it drops so fast, you may miss the patient that comes in after 24 hours because his IL-6 has already dropped. Then you have CRP. This is the green line here. And you can see this is a more, we use it a lot in Europe. And it's a slow biomarker, and it takes about 48 hours to go to the peak, and it's very slow. And it's more a biomarker of inflammation and not so much bacterial infection. And then you can see PCT, this is the blue line, and it takes about 6 to 12 hours to go to a peak. And then it drops. It should decline by about 50% every other day. And there is a lot of studies demonstrating that if this decline in PCT over time doesn't take place, that the patient is not responding to treatment, and the patient is, having a much higher risk for complications and also eventually to die from infection. So these were earlier studies, and here they just showed, the kinetics in a cohort of patients with sepsis, and you can see survivors and non-survivors. And you can appreciate that even in survivors, some of these guys had very high PCT levels when they come in, but they all showed more a decline in the marker over time, while in the non-survivors, this decline was not as as present. And so I think it's really important to understand that from a prognostic perspective, it's not the initial value. A high level just tells you the patient has sepsis, he's very sick. It doesn't tell you whether the patient will respond or not. And I think for this, we really need the kinetics. So when I was in Boston, now almost 10 years ago, we were doing a large multi-center studies, the MOSES study, and we collected blood levels in patients with sepsis going into ICU. And we measured these levels every 2 days. And we then compared, what happens if you could reduce your antibiotics, if you could reduce your PCT level over 2 days by 50% or more. And we found that actually this was a very high prognostic indicator. And even when adjusting the model, then the statistical model for other prognostic indicators such as SAP score or SOFA score, PCT provided additional prognostic information. And so a decrease over 72 hours was really, a very good prognostic indicator that the patient is responding, and eventually had about 50% lower mortality rate compared to the other patient population where PCT didn't decrease. But again, I think, the prognostic information is interesting. But we need to have biomarkers that actually influence our decision making regarding the management of patients. With prognostic information alone, you have not gained anything. You spend some dollars, on your biomarker, but you have not any return on investment. So that's why I'd like to discuss the second question. Well, if we use this information now regarding our treatment, are we going to be better physicians in the end? Are we going to use less antibiotics? Do we see any benefit for the patient? And I think it's important to understand that antimicrobial stewardship, it's not a one biomarker approach where you just look at PCT or any other biomarker. If it drops, you say, well, everything is okay. We stop the treatment. If not, we do not stop. But of course, antimicrobial bias stewardship, has different parts, and of course you need to take the biomarker as just one piece in this complex puzzle of the stewardship. And I think it's, of course, the 5 rights: the right drug, the right patient, the right dose, the right route, and the right time. And I think particularly the right timing and the right duration. I think PCT can give us some insights. So this was actually, shown also in different randomized trials, and I'd like to just share with you some of these trials. And the trials all had a somewhat similar concept. So patients with a diagnosis, mostly patients who had random respiratory tract infections, but there were also trials looking at sepsis, and these patients were randomized to a control group. This was always a little bit different in the trials, depending on the country and the treatment, population. But basically, it was usual care treatment compared to PCT-guided treatment. And so PCT-guided treatment means that for the intervention group, physicians received information on the PCT level. And with the information, they also received a likelihood that they should start antibiotics or continue antibiotics. And so for the patients in the ED or the patients in the GP, we had lower cutoffs were used in these trials because the background noise of PCT is just lower in these patients. So if you have a patient coming to the ED or the GP, you expect a very low PCT level if the patient is not infected. For an ICU patients, because you have, a lot of these patients have shock and they have bacterial translocation. So there is, a little bit of increase in PCT in all of these patients, but not, really meaning that these patients may have, bacterial infection. And so you can also see on the slides that we did not, that most of the trials did not use only one cutoff, but they had like different cutoffs, And I think the interpretation is if the PCT level is very low, so in this case below 0.1, chances of this patient having bacterial infection is just very low, and antibiotics should be strongly discouraged. Now, the more it increases, obviously the risk of bacterial infection, increases. And so if it's 0.1 to 0.25, it's still low, but it's a bit higher. And then if the level goes beyond 0.25 or beyond 0.5, then really, based on observational studies, the risk of bacterial infection is just increased. So it's a pretty intuitive, algorithm. So you look at the PCT level, the lower, the lower the risk, and you should, include this information in your decision whether to start antibiotics in these patients in the intervention group. So there's a lot of studies and trials that have actually looked at, this type of algorithm for different patients. And we have recently done a Cochrane meta-analysis where we pooled all these different studies. We did, one analysis focusing on the patients with respiratory infections, another one looking at patients with sepsis, to understand, particularly from a safety standpoint, what is the impact you have on the outcomes of patients if you use this type of algorithm. So this is the most recent PCT meta-analysis, and as you can see, it was a patient level meta-analysis. So this means we were able, from all these different trials, we were able to receive, original data for each of the patients included in the trials. And of course, this helps us not only to make an overall statement, but also to look at subgroups. So let's say we were able to take out all patients with pneumonia from all these trials and make a statement about what is the effect of PCT in pneumonia or COPD or bronchitis and other types of infections. You see, we did about 1,000 patients. We searched about 1,000, abstracts, and we had some inclusions. We only focused on the randomized trials. We then had 32 trials that were included in the aggregate data analysis. And we asked all these trialists to provide their original data, and we were successful in 26 of the trials, and for 6 trials we didn't receive the data. But these were also smaller trials and some from China where we didn't receive the data. So now when you look at the overall population, and again, this is patients with respiratory tract infections, and you can see that, overall, you have a reduction in antibiotics from 8 to about 7.67 days. So it's about a 35% reduction in exposure to antibiotics for the PCT guided patients compared to the control group. And so interestingly, it is different depending on the patient population. So for some patients, populations, we were able to, or the trials showed that you're able to reduce the initiation of antibiotics. And this is typical for the patient with bronchitis with COPD. And for other types, for sepsis or for pneumonia, the trials showed that initially you use similar antibiotics, but you have a shorter duration of treatment. And so you have both of these effects depending on your patient population. We also looked at patients with positive blood cultures. And this, of course, is one of the holy grails in infectious disease. Can you use shorter antibiotic courses if a patient has positive blood cultures? And so here you can see on the upper hand the start of antibiotics and the duration, and you can see that for overall and for different types of antibiotics, we found that that we were able to really reduce the duration of treatment by about 3 to 4 days in these patients. So for the patient with respiratory tract infection or a mild to severe infection coming to the emergency department, the concept is then that you have a patient coming in, you do a clinical assessment, and then you measure your PCT level, and you have your basic cutoff of 0.25. The lower the PCT level, the more you disencourage antibiotics, the higher, the more you encourage it, for the initial treatment. But then most importantly, for the ones you started, you do follow-up measurements, and you also have stopping rules. So once it comes back below 0.25, or if it drops by 80 to 90%, this would be a stopping rule for your antibiotic treatment. So again, for this patient, the COPD patient, and he's feverish and he has no infiltrate, and so for this patient, as a GP, as an ED physician, you think, well, probably, this guy doesn't have bacterial infection the way he presents, but you're not 100% sure. So the very low PCT level in this patient, would give you then a hint and would encourage you not to use antibiotics. But if PCT would be increased, it would encourage you to use antibiotics. And so these are the same data I've shown you now, stratified for the setting, and you can see for the primary care setting, that the data are quite impressive, because you have a reduction, of antibiotics from almost 5 days exposure per patient in the control group to about one, average of 1 day or 1.5 day in the PCT group. So in a GP, with a low risk patient population, I think the rule out is just, is very impressive. And you can see that on day one, you have from 60% treatment to about 20% treatment. So you have a very strong, influence. Now, for our second patient that I have shown you, now the one where we have established the diagnosis of sepsis or severe infection, the initial PCT level is not going to make a big difference, because once you realize a patient is septic, you're going to use your antibiotics, because that's, the key component of treatment. But then, it's more about the duration. And so for the septic patient in ICU, it's the higher cutoff that we need to use, so the 0.5. And it's not, so much the spotlight on the initial PCT level, but it's really more on the kinetic, on the monitoring. And so most of the trials have then also focused on a stopping rule. And you can see here PCT decreased by over 80% was the stopping rule used in most trials. And so if PCT dropped by 80%, then it was a recommendation to early stop antibiotics. So for this type of patients, it's similar, like if you have a patient with pulmonary embolism. So if you have a high-risk patient for PE, you're not going to wait for the D-dimers, because if he's high risk, you're going to overrule the biomarker anyway. Now, so in the case of sepsis, if a patient has a life-threatening disease, you want this patient, to use antibiotics right away. However, if the patient, has no life-threatening disease and is stable, you may want to use PCT initially. But more important then, is really the follow-up and the evaluation of the kinetics. And if it drops, by 80-90%, this is a pretty strong signal that the patient has recovered from the infection, and it is safe to reduce antibiotics, to stop antibiotics. And so here I show you the patient for sepsis, the data for the sepsis patients, and you can see on day 0 in these trials, and that's again all these trials together, we had about 100% antibiotic use in both of the groups. Again, because septic patients need antibiotics, so no biomarker will change that. But then you can see that, after day 4, 6, 8, you have a higher proportion of patients where antibiotics were stopped. And this results in a reduction of antibiotics by about 25-30%. So you have your clinical impact is really in the early stop of antibiotics. So it seems that, PCT, if you use PCT, you have lower antibiotic usage, right? But then you can argue, well, it's not, so hard. You can always, use less antibiotics. But the problem is you don't want to hurt your patient, right? You're giving the antibiotics because you expect that the patient will do better if he's treated correctly. So, so at least, if we have lower antibiotics, we do not want to see a decrease in clinical outcomes. So how are the clinical outcomes now in these studies? And again, I think here the meta-analysis is very important, because the meta-analysis has a lot of power, to show us whether an intervention, has any safety problems. Now, in regard to outcomes, there was a very important trial, the SAP study, which was a trial published by Evelyn de Jong in the Lancet Infectious Disease, and it was a large trial, multicentric in the Netherlands. 15 trial centers participated, 15 hospitals, 1,500 patients, and all of these patients were hospitalized in ICU with a proven or presumed infection. And, in addition to a lowering of antibiotics, the authors also reported that they had a lower risk to die from infection. And you can see the hazard ratio of the standard group was 1.26. So the standard group had about a 25% increase in the risk to die. The patients treated by a PCT algorithm had a lower risk to die. And so we actually found a very similar finding in the patients in the meta-analysis, looking at all these respiratory tract infection patients. And you can see here, 30-day mortality control versus PCT is 10 versus 9%, and it was an adjusted odds ratio of 0.83, which was significant. We also had a borderline significance. We found the borderline significance for treatment failure, about 10% low risk of treatment failure, no difference in lengths of hospital or ICU stay. And very importantly, we also had low risks of antibiotic side effects, something that is obvious, when you reduce antibiotics, about a 30% reduction in side effects. And so these effects were mostly seen for the ICU patients, but it was also seen in patients in the emergency department and the medical ward. So finally, we also did an analysis looking at, going beyond respiratory infection, looking at sepsis patients overall. And you see here, these are all different trials, different countries: France, Germany, Netherlands, Brazil, Germany, Belgium, Switzerland, Australia. So that there is a lot of these trials. It's very international. They all used, a somewhat similar algorithm, and so we were able to use this for our individual patient data meta-analysis. And you can see we found overall an odds ratio of 0.89, so again about a 10% reduction in the mortality, and this was independent of whether patients met the sepsis 3 definition or not. It was also independent of the organ failure score, the SOFA score, whether they had shock or no shock, although patients in septic shock, had a stronger signal, just looking here at the subgroup. And also in patients with renal failure or patients with different types of infections, they had a very similar, consistent result in regard to their mortality benefit. Now, of course, it's nice to see something like that, and I think it's a convincing result that in a lot of patients, a lot of trials, when you take it together, there is safety of such an approach seems to be very high, and patients seem not to have any adverse outcomes despite the reduced antibiotic use. But then on the other hand, you can say, well, why should you have a mortality benefit? And I think this is something that was not really clearly demonstrated in the studies, but there is different possibilities and different things that come with the PCT algorithm. So first of all, I think if you use PCT in your patients and you have a patient coming in with a sepsis kind of syndrome, but his PCT level is very low, you start to wonder whether this patient really has sepsis, or maybe he has another diagnosis that is just mimicking sepsis. And you all know that that sepsis is a very difficult syndrome, and some patients that are very sick may look like they have a sepsis, but they may have another diagnosis. And so PCT also may help you to use other diagnostic measures to better understand what's actually causing the problem. Second of all, obviously, longer duration of antibiotics have been linked to adverse outcomes, by secondary problems such as C. diff infections. And, overall, antibiotics are toxic drugs, right, which help us in the case of infection, but which are still, toxic if they're not needed. And so I think, treatment side effects that are reduced duration with secondary problems, and maybe some diagnostic improvements, may are the main causes which could explain these better clinical courses of the patients. We also, have looked at patients with heart failure as an example, and this is also, interesting because, in my practice, I often see patients coming in with heart failure, diagnosed with chronic heart failure. They come in, they have dyspnea, they have an infiltration on their chest X-ray, and then you're standing before the patient and you're wondering, is it more a pneumonia or is it just heart failure? And of course the treatment is quite the opposite, right? Because one condition you give diuretics, and the other condition you give fluids and antibiotics. So when we looked at our patients with heart failure, we found actually in these patients the PCT guided group had a much lower mortality compared to the control group, and this was also found for some other populations. So why is PCT not used more widely? And I think PCT does have pitfalls, and it's clear that PCT is not going to be the perfect biomarker for sepsis that takes away all our problems, and we have to appreciate that PCT does not have just one cutoff, such as troponin or D-dimers, but it really has different cutoffs, and we need to adjust the cutoffs based on the clinical setting. So ICU patients do have higher PCT levels compared to non-ICU patients. We do see false positive and false negative values, localized infections, subacute infections, they have low PCT levels, but patients coming in with cardiac arrest, cytokine storm syndromes, they may have very high PCT levels despite not having bacterial sepsis. So, we have to understand really the clinical management of the patient and add PCT on top. Also, I think that the single PCT levels, particularly for the patient going into the hospital, is of limited value, and I much more believe in the kinetics of the marker over time. And of course, PCT is not the new microbiology test. It does not tell you what type of pathogen you're treating. So you should always, integrate it in your other tests you have, and to understand what type of infection and treatment does your patient have. Also, I think importantly, that the assay is very crucial, and we need to use high sensitive PCT assays. And there is, particularly in Asia and some other countries, there are semi-quantitative PCT assays, point of care assays, and I think it's very dangerous to use these assays because they're not going to give you the sensitive information you need, and so this could be dangerous in a patient. And then, of course, there is, not all the trials have been positive. And I think the most important one is the data from David Huang and Derek Angus, the PROACT study. And so, in this study, the investigators didn't find that, PCT really didn't make a difference in regard to antibiotic use and in regard to clinical outcomes. So my big critique for the study is that the study really was done in a lot of hospitals where physicians had not much exposure to PCT, so they were not trained with the marker. They did not have any experience, and so I think if you just if you work there, you treat your pneumonia patients, always the same, and then all of a sudden you're using PCT, and you get a level and you're not used to it, it doesn't change your behavior right away. So I think it really needs, some understanding of the marker. It needs the will to change your treatment, according to it. And I'm not sure, how well this was transposed in this trial. And so in the end, the trial just showed that, if physicians are not adherent to the strategy, you're not going to find any differences in outcomes. And I think this is an obvious finding, which is important. And it tells us, if you use PCT, we need to use it with guidelines, with education, and I think this is a key message for me from this trial. And also, in regards to cost, I mean, PCT still is a biomarker that produces costs, and there is a couple of studies, and this is from Derek Hayland, and they found that if you use PCT and you change your antibiotic management, it is actually a very cost-saving strategy. Now, if you use PCT, but you're not going to change your antibiotic management, you're just going to waste a lot of money. And again, I think this is key that, if you use PCT, you need to change your clinical behavior based on the marker. And otherwise, it's not going to be well spent money on the marker. So what's the evidence today of PCT? And I've shown you some of the studies, and I think most of it is really respiratory, sepsis, some are post-operative infections, there's some meningitis trials, and so here we do have strong data. There is a lot of other types of infections, endocarditis, pancreatitis, abdominal infections. I think here we still need more randomized data to understand, how best to use PCT in order to make a difference and also to be safe regarding clinical outcomes. Now we do have, of course, another target in mind, which is COVID-19. And there has been a lot of interest also for the COVID-19 patients, and how should we use PCT for these patients? And I think there is not a very clear message now, whether PCT can be of help in these patients or not. Personally, I've seen patients, especially the very sick patients with COVID-19, that had, increased PCT levels. And, we didn't have any evidence for bacterial infection in these patients. So I'm not sure whether in this scenario, PCT, is a good indicator for bacterial infection. I would put it the other way. So if I have a COVID-19 patient and his PCT is low, this is telling me that this patient may not have very severe disease and may not have bacterial superinfection. If the patient has a high PCT level, and he's very sick, I'm not sure whether this is just based on his general sickness and translocation of bacteria in the guts, or whether this is secondary pneumonia. But I'm sure there's a lot of trials and studies being published regarding COVID-19 patients, and I'm sure we're going to learn how to best use PCT and other biomarkers to better monitor these patients in the ICU. So, in summary, how should we use PCT? And I think there's two basic models. So the patient outside ICU, and of course, first we need to have our initial clinical assessment. And based on the assessment, we come to the conclusion that infection is uncertain or is highly suspected. And then, we do our PCT result, and if PCT is low, it gives us a low probability. And, if a patient is clinically uncertain and has a low PCT, we go to a very low risk of bacterial infection. And so for this patient, we should not use antibiotics if the patient is stable. If PCT is increased, then I think it's better to use PCT. And if we have a high initial suspicion of bacterial infection, we should use PCT. We should use antibiotics, but we should remeasure PCT. And if PCT remains low, it may be safe then to early stop antibiotics after day 2 and 3. And I think importantly, we should also look for other diseases and illnesses causing, fever and sepsis-like syndrome. In summary, I think PCT on admission is helpful to evaluate the patient. In a low-risk patient, it can really help us to rule out infection. In a high-risk patient, the patient where we have established the diagnosis of sepsis or infection, it is just giving us a baseline. Then, I think if you take the patient in the hospital, it's an important marker to monitor the patient. We would expect if a patient is responding to treatment that his PCT is dropping, and this tells us that the treatment was effective. If it's not dropping, it tells us something is not, well in the patient. And I think it's then important to go back and do a re-exam to understand why this patient may not be, responding. And then, if a patient is responding clinically and has a decrease in PCT, then the trials have shown that it is safe to stop early antibiotics. And by doing that, you can really have, an impact on side effects from antibiotics. And by that, you can also have an impact on the clinical mortality and other clinical outcomes of your patients. And so with that, I'd like to close and thank you all for your attention. I think we will have some interesting questions and points for discussion. And I'd be happy to share with you some more thoughts there. Thank you very much.
Great. Thank you very much. That was an excellent, very comprehensive talk. Nicely highlighted a lot of the work that your group has done in this area. I was going to clap, but I don't think you would hear it anyway. Yeah,
Thank you.
there's two questions that have been submitted. And the first one was, will the event be recorded and shared with us? And I've been told that it will be shared and be available to registered participants in about 48 hours. I think the tape has to be cleaned and everything, but it will be available to registered participants in about 48 hours. There's a second question, is how can PCT be used during the flu season? I guess you mentioned a bit during COVID. I guess somebody else has now raised the issue, but can it be helpful in flu season?
Yeah. I think flu is one of these diseases which causes a lot of GPs and a lot of doctors to use antibiotics, despite antibiotics may not be helpful in this case. So if a patient comes in and you are not sure whether he has the flu or not, and PCT is low, it really argues against a bacterial infection. And then we have in the hospital, we do have a lot of patients with flu, and then they have like a second hit, so they start to have fever and they get worse, and then you get worried that these patients actually have a bacterial super infection. And I think for these scenarios, the increase in PCT has been shown to really point to bacterial superinfection, and these patients are at increased risk and should receive antibiotics. So if a patient has a fever, he has the flu, and he's still having a fever after 2 or 3 days, and his PCT goes up, I will get worried about the patient, and I would consider doing more diagnostic tests and also use antibiotics eventually.
I guess, is it worth clarifying how specific is PCT to bacterial infection versus a viral infection? I guess for either influenza or COVID now, right? I mean, should it be low if it was just a viral infection?
Yes. So if you have a patient and that he is stable and he has a viral infection, then his PCT is gonna stay low. And I think there is a lot of data backing this up, right? It's more problematic if you have a patient that is really sick. And so a patient with COVID and he's intubated and he has really, he's in shock. He's in respiratory distress. So because he's so sick, he's going to have a lot of cytokine activation, and he will have some, increase in PCT. So PCT loses a little bit its specificity in a highly sick patient. And this is why I don't think it's a yes/no answer, but you have to look at the PCT level, in conjunction with your clinical patient, and the patient that is doing well. You expect PCT to be low in a viral infection.
Another question just come in now is the role of procalcitonin in sepsis with acute kidney injury. Is the procalcitonin falsely elevated in AKI? And if yes, do you still monitor every 48 hours? That's the question.
Yeah, that's actually a great question. PCT in AKI, so the kinetics is different, and it goes down. It just drops more slowly, but still, a lot of these sepsis trials have had patients with AKI and with a decrease in renal function, and they found that PCT still, has still can help you to reduce your antibiotics. So in AKI, I believe you have to expect a slower clearance of PCT, but you can still use it and monitor it for your antibiotic decisions.
The question about pediatrics, would you be able to speak to pediatric data regarding PCT? Is it as robust in pediatrics as it is in adult medicine?
Yeah, that's also a great question. So there is also trials for the pediatric population, So I think for the pediatrics, it's also the kinetics over time has also been shown to be helpful. So in a kid with a bacterial infection, you would also expect that PCT, decreases. And if it doesn't decrease, it tells you that this kid, the infection is not well controlled. If it does decrease, it also tells you this kid is really responding, and eventually you can stop antibiotics. I'm not sure about the initial PCT level, how well this has been shown, and importantly, in the first 48, 72 hours of life, kids have just after birth they have an increase in PCT, and so this is a physiological increase within the first hours of birth, and do not mean that the kid is the baby is having sepsis. So this is a little bit of a caveat.
I don't see any other questions at the moment. I had a question. You talked about this during the talk about the improvement in mortality and the kind of reasons for it. And I find that actually quite fascinating because the question is why does it improve mortality? You mentioned a few things that I guess in one sense you might be able to rule out infection and find another cause for the deterioration, or it could be secondary infections like C. diff from too much antibiotics, or I guess volume overload from the fluids given by the antibiotics. From your studies, were you able to kind of tease that out a little bit? And I mean, it would require the studies maybe identifying the cause of the death, which are always problematic in any of these randomized trials. But I don't know if you have any comments on that. It's fascinating.
Yeah, I think it's an interesting question. It's an interesting question. And, there is a lot of observational data showing that if you overuse antibiotics, then you have an increase in mortality in your patients. So this is also why all the sepsis guidelines recommend to use antibiotic stewardship tools, to reduce antibiotic duration, because of obviously you have the issue of resistance, but also you have for your patient, you have an increase in the risk to die if you just overuse antibiotics. I think PCT is just by reducing antibiotics and also by giving you probably some monitoring feedback on the patient. It also gives you some information. Now, there was a couple of years ago, there was a study from Sweden, and this study, looked whether you could reduce mortality by early escalating antibiotics. So basically, they looked at patients, and if PCT didn't drop or increased, they started to do CT scans, and they looked for abscesses, and they added other antibiotics to the patients. And so this trial actually wasn't positive, and by escalating measures, it wasn't able to have a positive effect on the patients. So personally, I believe that just if we use just what is needed for the patient, and not more, I think this has really positive effects on the patient's outcomes. And I guess this is one of the reasons why we see that. And it was interesting in the trials. I mean, there was this one study from the Netherlands which had a huge mortality benefits, but also when you look at different other trials, you always could see a little bit of a benefit, but it was not significant, just because there were not enough patients. And so in the meta-analysis, the signal really got picked up and was statistically significant in the end then.
Yeah, no, I think that's the advantage of your meta-analysis. You were able to kind of tease that out a little bit more. And the other topic you talked about, also thought was interesting, was that how in many areas it's not used. I'm from a center where we don't use it, and the question is, so why people don't use it, and I think it's probably a balance of the costs of it and the thought that that you may not change practice. And I think you mentioned that it's only kind of useful to use if you expect it to change your practice.
Yeah, exactly. And also, I think the New England paper, of course, has also had some effect. And I see that there's like two types of physicians: the ones that believe in procalcitonin, and the ones that do not believe. And for each one, they have their trial now. The ones they say, look at the meta-analysis, it's clear, it's a huge benefit. and the other ones, take the New England paper and say, you see here, nothing happened, right? So I think, basically you need a high motivation to want to integrate this into your practice. You need to be able to change what you have done the last 20 years. If you have treated all your pneumonia patients for 10 days the last 20 years, and you say, well, it always worked well, right? Why should I change that? You should really be then say, okay, I want to try something else. Maybe they only need 3, 4, 5 days, right? And I think it needs this basic motivation to want to change it and challenge yourself as a physician. Because and this is something I learned in the trials. That a lot of the GPs, they told me, this patient comes in every year with his cough, and I always give him antibiotics. He always gets better, and everything is okay. And now I don't do it, and he's still okay. Maybe I was doing the wrong thing for the last 10 years, right? And so, this, it also challenged a little bit ourselves, because I think we physicians, we try our best for the patients, but in the end, we are still, looking in the dark a lot of the times, particularly with infections where we do not have great gold standards, to tell us, is it really bacterial or not? How long do you really need to treat a patient? For most patients, we just don't know, right? We look at fever, we look at blood pressure, we look at, experience from the past, but we just don't know. And so I think it just challenged a little bit also our clinical duty, our clinical experience.
2 other questions have come in. Let's see if we can squeeze them in before the end of the hour. One is, have any studies evaluated the use of procalcitonin in conjunction with other biomarkers to de-escalate antibiotics, or using 2 biomarkers at the same time?
Actually, that's a great question. So I'm not aware of it. So there was one study from the US that has combined like a PCR with procalcitonin, like a PCR method. And so the concept was that, if you had in your PCR, if you would find, evidence for a virus and you would have a low PCT level, then, you would have strong evidence to not use antibiotics. So I think this is probably the future, right? Because currently our tests regarding microbiology pathogens are really not there where it should be. And so for most patients with respiratory infections, for example, we just don't know what's going on in the patient, right? Because cultures are about 10% positives, and all these PCRs, they have not great sensitivity. And also, if they're positive, you're not sure whether it's a secondary infection, if it's 2 infections. But once we have better tools there, and then we should combine tools looking at the pathogen and tools looking at the host. And so PCT is a typical host response marker that can tell you about the patient, and the other PCR tests that can tell you about the pathogen. And I think having both information, certainly will give you best information.
The last question here: does the PCT role in intraperitoneal infections have the same role as in respiratory infections?
Well, there is. So most of the data has really been generated for the respiratory tract population. And I think because the lung is a huge organ, you do see like a huge increase in PCT because there is, a big organ that is infected. So I think for respiratory infection, this is really PCT has been, has generated very solid data. For other types of infections, there is just not as much experience. But I think from a principle concept, it also works, but it's just not as well evidence-based, in my opinion.
Great. Now, thanks again for such an interesting talk, and also for taking these questions. I think there's quite a few questions from different areas, which showed an interest in the field. And as I mentioned, I think the talk will be available in about 48 hours. Thank you to everyone for joining this virtual event, and take care of the rest of your day, wherever that may be.
Thank you all.